Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is the importance of public policy in cancer care. And we've got like a double expert with us. So our guest tonight is Dr. Austin Baeth. And we'll get to know Austin, but Dr. Baeth is not only an internal medicine specialist at UnityPoint, but he's also a member of the Iowa House of Representatives. So welcome.
Thank you very much.
So before we talk about our topic, we always like to get to know our guests. So tell us, where you from? Where were you born?
Yeah, so I'm an Iowa boy. I
Okay.
was born and raised in the northwest part of Des Moines and went to Hoover High School and went on to University of Iowa for undergrad.
Okay, wait. Back to Hoover High.
Okay.
So Hoover High, how many in your class?
Maybe 300.
Okay. And what was your claim to fame in high school?
Oh, I love that icebreaker. Let's see. It's funny. Maybe it's not funny. My wife and I, who we never knew each other in high school, but she went to Roosevelt, another Des Moines high school. We both were voted biggest ego in our graduating class, which, and apparently it's because, like, for me, I didn't talk to like other kids as much. It's because I was shy.
Okay.
Not because I thought I was better than them.
Were you like class president?
No.
Student body president?
No. Captain of the soccer team.
Okay.
I pulled off a big heist. I was the ringleader of a heist for homecoming where we set up a living room on Urbandale High School's lawn. So I ended up becoming notorious, I guess, for that, and was pardoned by the time I graduated. So I didn't have to serve time.
Okay, well, good. Yeah, that could have interfered with your political career. Yeah.
Well,
probably not your doctor career
right now, because I don't think that was dug up yet.
Yes, the biggest ego. I don't think we had that as one of the categories in high school. So then from Hoover High to the University of Iowa.
That's right.
And did you know when you started college that you wanted to eventually become a physician?
I knew in 7th grade.
Really? How did that happen?
My grandmother, who went to the doctor a lot, not because she was necessarily sick, but because she was a hypochondriac, developed a strong relationship with her primary care doc. And so, kind of worshiped him. And she was driving me to school one day in 7th grade, and she said, "Austin, you've been doing so well in class. You're so smart. You could be anything you want to be. You could even be a doctor." And before that, I was going to plan the NBA or something, I'm pretty sure, until I found out I was going to be the height I am. But I said, "Okay, Grandma, that's not a bad idea. I'll look into it." And things just kind of fell into place after that. I was a patient transporter at Methodist hospitals starting at 16. So wheeling around patients in wheelchairs and gurneys, and that kind of got me an insider's view of what it's like to work in the health system, and also, kind of a view of what it's like to struggle with illnesses.
Mm-hmm. So your undergrad major was?
In the end, it ended up being, I bounced around a lot. It ended up being physiology.
Okay. What did you bounce between?
I was in art. I was in biomedical engineering. I was in political science. Did a little Spanish.
Okay. And how many years undergrad?
Still only 4 years.
Okay, good.
Yeah.
Good. Yeah. And then where did you go for medical school?
Then University of Iowa for medical school. I took a year off. I had, actually, as a dermatologist here in Des Moines, Andy Bean was my dermatologist, and he said, "Austin, if you go into medicine, you got to know it's going to suck you dry." And he said, "So if you're going to do anything in going into medicine, you got to live your life up as best you can beforehand."
So you had 1 year.
So I took a year off,
your life,
and I bought around
the ball and chain.
That's right.
Okay.
That's right. Bought an around the world ticket and traveled for an entire year, staying in hostels and on strangers' couches, 26 different countries.
It's very European of you to take a gap year.
Right. Yeah. My father was not approving. Yeah. This was not the American way.
Yeah. So a gap year of traveling around the world,
Mhm.
and then medical school. How did you make the decision to go into internal medicine?
I always wanted to do primary care. I think probably influenced by growing up with hypochondriacs, my grandma and then my mother, who, it's one thing to treating disease is really important, but it's also to have just a partner in health to be able to share your concerns with. Since we only have one vehicle through which we go through life, it can oftentimes be the source of some of our greatest anxieties. And so for me, I found a lot of value in being that person, whether you are actually sick or just concerned and actually going to be okay. I like serving that role of being that person, that first phone call to try to help figure it out.
Yeah.
And I like having that relationship with patients and just getting to know people.
Very important. Even as we mentioned before we started filming, as a cancer doctor, I realized that one of the most important things for a cancer patient is to have a really good, trusting, caring relationship with primary care. And before a patient ever becomes a cancer patient, if you don't have a diagnosis of cancer, it's your primary care doctor that helps guide you through what do you do to prevent cancer, and what do you do to get your screenings, and when do you get your screenings, and are you going to get them or not? And most of that is really dependent upon having a really good, sound, caring relationship with a primary care doc.
Right. I think for some of my patients anyway, they tell me they come back just because, well, I've got one, for example, saw a guy last week who hates doctors. And I'm pretty sure he actually probably has some, I think, a grave illness, but he will not treat it. But he'll come back just to see me. He won't do his colonoscopy, won't do this, won't do that. But he'll come back just to check in once a year. I'm not exactly sure why, because he doesn't take any of my advice. But still, for some folks, I think it is important to have that trusted person.
There's something healing about just being in the presence of someone who cares about you.
Right.
Yeah. So, as if being in medicine in this day and age isn't stressful enough, you decide to run for Congress. So what's that all about?
I think there are two factors that led me to that. One is in primary care, I see folks every week, maybe every day, for whom I can't help because the main things that make them suffer are their various other strains on them from a socioeconomic status. People who have fallen through the cracks. And all the prescriptions in the world that I could write them will do no good because maybe they can't afford it, or they don't have insurance, or they don't have stable housing, or they need to use their money to pay for the next meal, or maybe they couldn't even get to see me because they don't have a car and can't afford a bus pass. And I think for me, ethically and morally, it just seemed wrong that living in the wealthiest country in the world, in the history of the world, that we still have people who don't know where the next meal is coming from. Right here in Iowa. In fact, 1 in 10 Iowans don't know where their next meal is coming from. So I can't begin to talk to them about their diabetes and their high blood pressure if they don't even know where their next meal is coming from. That takes priority. If you look at Maslow's hierarchy of needs, healthcare comes after some of these other basic needs like shelter, food, and water. And in my observation of the political sphere, these folks have least voice in our political process. And I think we know from the various government experiments across the world that it does take government to help out poor people and to help out people in some way or another who've fallen through the cracks. It just does. And if one believes in I'm probably showing my political stripes here. But if one believes in, pure limited government and, survival of the fittest, go to some countries that are developing, and you'll find that the lack of government involvement just creates more poverty, more people suffering.
And it's been an evolution of our country in terms of what we expect our government to do. And there was a time, maybe a couple hundred years ago, where it wasn't necessarily expected that government was going to provide education. And actually, Iowa was one of the leaders in determining that, yes, we will use tax money to provide K through 12. And now I see or hear very few people who don't think that there's a role for government to provide K through 12 education. Most people accept that. But yet this idea that the government should provide health care, like a universal health care, is still thought to be, oh my gosh, that's un-American, that is communist, that is, but there's not that big of a stretch from expecting a government to provide K through 12 education for everyone, regardless of whether you are poor or wealthy, to the government providing something as important as health care for everyone.
Right. I think that, and I don't know that this is able to apply to all countries of the world just due to the lack of resources, but I think that our country has gotten to the point where we have resources such that healthcare should be considered a right, an access, a right to access, like it is a right to access water.
And we could certainly do it much less expensively if we had one system all working together.
Yeah,
the whole country on one EMR.
It's ironic that I think that, you talked about socialized medicine or universal medical coverage. And it's, it causes kind of the red scare in people that that's so un-American. But we do have a socialized medical system here in the United States. And it's called the VA. Our vets are in a socialized medical system. And I cannot think of any folks who are more patriotic and deserving of, American pride than our veterans, who are benefiting from a very efficient medical system.
And in many ways, Medicare population are also kind of a bit of a universal payer.
Right.
Not quite, but close to being that sort of a model. When we talked about why did you go into politics, and I appreciate your answer, I kind of think of it also along the lines as you and I as doctors, we can, every 20 minutes or every half hour, we have the ability to impact some person's life. But with public policy, you maybe have the ability to affect millions of people's lives through public policy.
Right.
So some of us get engaged with public policy by, one day a year going up to visit our congressman or writing letters. But I admire those of you who have the courage really to put it on the line and go to the ballot and get voted on, and then to have two careers. The 3 months you're up on Capitol Hill, or maybe 4 months, but I know it's not just a 4-month job, that you're still working on things. So you were quite active this legislative season, this session, and I know you had several bills that you introduced related not just to health care, but actually to cancer care. Maybe let's talk a bit about some of the issues that you brought to the State House in terms of a bill. Maybe help us understand some of those issues, and then what's the process by which one puts together a bill and actually gets it through committees and gets it voted on.
Right. Well, the impetus for my main mission in this last legislative session and those that'll come next for really trying to focus on fighting cancer is the fact that Iowa is in the middle of the cancer crisis. As I'm sure most folks watching this are aware, we have the second highest cancer rate per capita in the country, even when that's age adjusted, and it's the fastest rising cancer rate in the country. So we will soon, quite unfortunately, probably be number one, the cancer capital of America. Right now, it's Kentucky. Kentucky, we believe we know why they have the highest cancer rate, and it's because they have a much higher smoking rate. Iowa's smoking rate is about average. We don't have, so to speak, a smoking gun to exactly explain why Iowa has the second highest cancer rate in the country. And that news first came out about a little over a year ago now, when that was first found by the Iowa Cancer Registry, and their latest survey that came out this last early spring showed the same, still number two, but rising still fastest in the country. And nobody in the Capitol was talking about it. And, my very first year, I didn't know much about the ropes, and you kind of learn as you go. And I started to realize, well, maybe I just need to start talking about it. And I approached the Iowa Department of Public Health, and they weren't yet talking about it. And it was a little bit alarming to me that the folks who are in charge of keeping Iowans safe from a population health standpoint didn't necessarily have the resources allocated to figure out why we have a cancer crisis. And so that's what kind of got me going and trying to figure out, what do we need to do to start investing state resources into, number one, finding out why we have such a cancer problem compared to other states. What are those additional risk factors and causes that we haven't identified? And number two, there are plenty of other known causes of cancer that we could do a much better job mitigating, like smoking, like radon, obesity, alcohol use. And so it was a year ago, last summer, where I started to compile basically a portfolio of anti-cancer legislation that I drafted. And my first task was trying to figure out, how do I get the rest of the Iowa legislature to listen to me? Because I have one big obstacle in that, and it's the fact that I'm a Democrat. And right now, our political environment is hyper-partisan, and it's hard for the minority party. If you're in a Democratic state, I think it's going to be flipped, but it's hard for a minority party member to get a bill passed, and for that bill to even see the light of day, to even get a vote. So quite fortunately, my Republican friend who sits right next to me, his name is Hans Wills. He's a representative from Ottumwa, who, like everybody else, has been affected by cancer, either personally or with a loved one. Said, all right, Austin, let's do this. And he partnered with me on that. And I helped provide the content, and he helped push it through. And so out of 15 bills I wrote, he was able to get eight introduced into the House. And we had 2 or 3 pass the House. And that's where the rest died. And I can get into kind of specifics of the bills. I was told that was a success, because the average bill to become law takes 3 to 5 years. It takes that long to convince enough people to vote for it and convince the governor to sign it. And so I was told that going from my 15 bills I wrote to 8 introduced to 2 or 3 passed in the House was actually a success, especially for a Democrat to have written them. Of course, a lot of people didn't know I wrote them. Now they'll know. So we're just going to keep working. The main thing we got to do is start to turn up the volume and help more Iowans understand the problem, and then also help through them, help more legislators and lawmakers understand the problem and the urgency of it.
And you're right, cancer is not a political issue. It's not like there are people up there for cancer and against cancer.
Right.
So we're all on the same team. And in order to get something through, you need to partner with Republicans who also have the same understanding of the importance of cancer. Right. Let's talk about some of the bills specifically.
Yeah.
Before we do that, let's talk about a bill that I know was a success this year, and that was the biomarker bill. So that's one that I'm not sure if you were a co-sponsor. I know you were a supporter of that bill, and that's one that we've successfully got through both chambers, and the governor did sign. And I know some of the people in the room were with us when we went up to the State House and lobbied for that bill. We know that in terms of cancer care and many other diseases, that we now have ways of testing cancer cells to determine specific biomarkers that the cancer cell may have, that it specifically allows us to do the best possible treatment. And the bill was just to mandate that if it was medically necessary, insurance companies had to pay for it if it was medically necessary. And so that was a bill that did successfully get through. And so thank you for your support of that bill.
It's thanks to all of you.
And it's thanks to, that maybe talk a little bit about what you see as the role of the citizen lobbyists when you see cancer survivors that are up there at the state capitol lobbying, talking to their senators and representatives about bills.
Having citizens come up to the Capitol, I think, is the most effective way to get a bill across the finish line. We lawmakers probably receive emails and calls about hundreds of different issues in a year, hundreds. And sometimes they're emails that are kind of form emails. They're written for you, and you just put your name at the bottom of it. And we'll see 100 emails that look exactly the same. And I'm going to be honest, they usually are immediately deleted after you've read one of them, if at all. But when you have somebody in the flesh come up to that Capitol and look you in the eye, face to face, and most importantly, tell you their story, that's what works. They say that statistics don't bleed. So the emails and the calls where you talk about, where you just throw out stats. This is why you should support this issue, because of stats. Stats don't help you see the person right in front of you, the real life person who's affected by policy. And so when we have folks come up and tell us their story, it not only changes to change your mind, you got to change your heart. And that's how you get it done, is you got somebody who might have been on the opposite side of an issue, maybe because they had a lobbyist who they were good friends with, wanted them to vote a certain way. But then they saw an actual human being who was personally affected by this issue. And they realize he could have been my brother, or he could have been me. That's what changes hearts and minds. And that's why it's most effective to have everyday people come up and talk to their representatives and senators. And you can do it by phone call. You can do it by email. Just have it be authentic and have it be a story.
Right. Storytelling is important. Yeah. And, kind of one of the things with when I'm up there with cancer survivors and, where you're sort of coaching how to tell your stories, just tell your story. You don't have to memorize all the statistics. We can have those on a piece of paper to leave by in terms of all of that. Just your story is important. And also, I would say probably 80 or 90% of lobbyists that are up there because of a financial interest of some sort. And I always tell you, we're not up there because we're trying to pad our wallets. We're up there for life and death issues. We're not up there just trying to lobby for a tax break or a tax incentive or this or that. We are there, we really do have white hats, and nobody up there is for cancer. So yeah, putting a face on it is really important.
If I could tell a story, I had somebody come up who lived a couple counties away, a gentleman, maybe around 70. And he came there and he apologized in advance. He said, "This is going to be kind of raw for me." And he said that his wife had just died of brain cancer 2 weeks prior. And he wanted to know what we were going to do about it. And I think that was his form of mourning and turning his loss into action. And I said, "I want you to meet with this person and this person and this person, because we need to see that this experience is being multiplied way too many times in this state. And we need people to know that, to be able to see his grief and take from that action." It really works.
Thanks for sharing that story. Let's talk a bit about some of the specific bills. So maybe the ones that got the farthest along.
One involved radon. So Iowa has one of the highest radon rates in the country. In fact, every single county the EPA has rated as the highest risk for radon, such that 70% of Iowa homes have radon levels above EPA standards. 70%. Yet only one. Even if you're in an apartment, if you live second floor or below, you can still be exposed to radon. So it's tough I had a couple bills that would get at one, provide free testing for radon. That one didn't make it as far as I had hoped. But one bill that folks have been working on for a long time was for new housing to require passive radon mitigation to be built into new homes. It costs maybe $300 to $500 for this to be done, and it's a permanent protection against radon. And we're in a housing crisis right now, so there's a lot of home building going on right now, and radon is never leaving this state. It's in our soil. So why not, start to chip away at the issue as we get more housing stock, make them all low risk radon. The home builders historically have been against that because it adds cost to building. And this last year in the House, they said, all right, we'll lay down our arms. We got bigger battles to fight. And it passed the House unanimously. And people who'd been in that business for a long time were shocked that it got done. And I think it was probably because more and more people are becoming aware that we got a cancer crisis. As it pertains to radon, it's estimated to kill maybe 400 Iowans per year. That's as much as car accidents. Second leading cause of lung cancer. Leading cause of lung cancer in non-smokers. So we're going to go back with that same bill next year and see if we can get it all the way. And we didn't exactly talk about the process for how a bill becomes law. I think there's some sort of cartoon that had a song about that. I can't remember exactly how it goes. But a bill is introduced in either chamber, the House or the Senate. It's assigned to a subcommittee of 3 members. That needs to pass there to go to the full committee. If it passes there, then it needs to go to the entire floor of either that House or the Senate. And if it passes there, then it needs to go the opposite, do the same process again. And then if it passes there, then it goes to the governor for signature. That's 7 different steps. So the most steps I got were 3 for some of those bills. And being told that's okay. Mm-hmm. We'll keep going on for step 4, 5, and 6, and 7.
And because obviously it'll be a new session, so you really start all over again
right
next year. So the radon was one of the bills that you submitted. What was another one?
probably my highest priority was devoting state resources to figure out what is causing our excess cancer rates compared to other states.
So state funding of research
State
for
funding
cancer.
of research of cancer epidemiology, trying to figure out what's driving those excess numbers. And that type of research, cancer epidemiology, is not that expensive. If you look at our state budget of $10 billion, this could be done with the tiniest fraction of a percent of our state budget. It was even a generous amount, asked for $2 million. It could probably even be done for quite a bit less than that. And this would be for the Department of Public Health to hire a cancer epidemiologist and additional staff and resources to carry out that work, to maybe contract it out to the University of Iowa or elsewhere. But when you look at all of the both human and economic consequences of cancer, the return on investment of figuring out what is driving our cancer crisis is far worth it.
And how far did that one get? Did you get a
not the
co-sponsor?
It didn't get far. It basically was considered by committee in the budget committee of Health and Human Services Committee, and was put in a trash bin, I presume.
Okay. One bill that we really need to do here in Iowa is in order to lower our smoking rate. We know that the best way to decrease the number of smokers in Iowa is to increase the cigarette tax by $1 or more. And we have not raised the cigarette tax in Iowa for 12 years?
2007, I believe.
Oh, so even longer than that. And we know from all over the country that measure does have significant impact on the number of smokers. But because it's considered a tax, there are sort of some folks who believe that tax is just an evil word, and that even a tax that would result in less pain and suffering and fewer deaths is just dead on arrival to some people.
That's right. So we did introduce that bill. Now, we kind of baby stepped it. In an ideal world, you wouldn't baby step it. You want a tax increase to be a minimum of $1, if not $1.50. You want to feel it and make that decision. Oh, it's too expensive now. I'm going to have to quit smoking. But knowing the political climate we were in, asked for a smaller increase in the taxes. I think it was 63 cents, something like that, to get to an even $2. I think we're at $1.36 right now, if I'm remembering now. It was politely considered and debated and then voted down. Now, you discussed the avoidance of taxes, of raising taxes, and you're right that especially right now, the controlling party is wanting to reduce taxes, if anything. But politically speaking, political philosophy-wise, excise taxes or sin taxes have the best political appetite across the aisle. And so we thought, if you're going to raise taxes in some way, this might be our shot to use that money for cancer mitigation, fight cancer. It probably is not going to happen in the state of Iowa for a long time, based on what I observed. And the main argument against it was that this would hurt our gas stations along our borders of Iowa, because especially the Missouri border, because Missouri has the lowest cigarette taxes in the country. And so if taxes are that much higher in Iowa, people are going to drive past those gas stations along the border and go into Missouri and bring back their bootlegged cigarettes. So we did not have an increase in tax for our owners of gas stations along the Missouri border.
So it makes for strange bedfellows in terms of the public policy. How about another bill that you put forward this year?
Another thing that I thought, maybe it's got a chance was regarding tanning beds. So the World Health Organization has labeled, and along with other organizations, has labeled tanning beds as carcinogenic. Like, without a shadow of a doubt, tanning beds cause cancer. There's no such thing as a safe tan. A base tan is actually a fallacy. A tan is actually the beginning of a sunburn. And there's no such thing as a safe tan. And tanning beds cause cancer. We know that. It causes melanoma. So, in the state of Iowa, and we're one of the few states remaining, you could be 8 and go to a tanning salon, ride your bike there, and get a tan. There is no minimum age to go get an indoor tan. We have an age to smoke other known carcinogen, but we don't have a minimum age to go to a tanning bed. And so I thought, most other states do this. Why not we say you got to be 18 to make a big decision like that, to get a tan and increase your risk of melanoma? And that made it through subcommittee and then died in committee. But there were enough people who showed interest in it, and it probably would have passed committee, but some of the leadership higher up in the House, I think, said it's going to be a no-go. And I think probably hewing to the political philosophy of, maybe libertarianism, or, I'll do what I'm going to do, and my 8-year-old's going to do what they're going to do, or I'll decide if my 8-year-old gets a tan or not, sort of thing. So I'm not losing hope on any of these things. I'm hoping as more people understand what's at stake here, that we'll begin to move the needle further.
Well, Austin, I think that your dual role as an internal medicine physician and a member of the House of Representatives. So for people who don't know how easy it is to actually go up to the Capitol and talk to your representatives, I imagine we have some folks that are excited to be in the room with a representative to maybe give you some advice, ask you questions, and give you some advice for what bills they might want you to propose. It. So you ready for this?
Absolutely.
Okay, get the microphone ready. We're going to turn it first to our live studio audience. But if you're watching us live streaming, we invite you to submit a question to Dr. Representative Austin Baeth. Just put it in the comments section. We'll keep an eye out, and we'll turn it first to Poon. You're ready to go?
Yes. Dr. Bates, thank you so much for all you do and for these bills. And I know the biomarker not only cover cancer. Would you like to share a couple other things that may cover for our audience?
I'm actually not familiar. I didn't work on that bill.
Okay.
You
did vote for it, though.
I absolutely voted for it. So, we use biomarkers for various different things. And so I didn't read the text of the bill where it talked about how inclusive it was. But I presume it also probably helps with other cancer screenings and probably other autoimmune conditions that we use
and
to
neurologic. Yes. Yep. So, that was kind of news to me. I was familiar with all of the biomarker, the importance of biomarkers in cancer, but being and part of the committee and subcommittee hearings that I was at, learning of the role of biomarker analysis in some of the neurologic, mental health, and autoimmune diseases, that it plays an important role for those as well.
As an example, we're learning more about using biomarkers for diagnosing Alzheimer's. Mm-hmm. And we actually have an exciting treatment that was just FDA approved in the last year, and more in the pipeline. But you have to be able to confirm that the type of dementia is Alzheimer's type of dementia. And we finally have a safe way to be able to confirm that using biomarkers.
Yeah.
That wasn't possible before.
And just on the news today, I heard it's out of England that there is a biomarker assay that may be predictive of whether you will develop Parkinson's disease. So I suspect we're going to find many different diseases, especially that take time to develop, that we may be able to find some biomarker assay that our body is indicating the likelihood of a disease developing. Another question, Angelina.
I have a question, and I don't know how it came about that they didn't allow smoking in restaurants and even the airplane. I'm thinking, great, because as a child, I found I was allergic to, had a reaction to cigarettes. I mean, my brother, who was an X-ray technician at the time, was a cigarette smoker. And I came home and said, hey, we have to get rid of our brother because he, I'm allergic to him. So even if it's on someone's clothes, it triggers my asthma.
Right.
And it can actually, I have to go get a nebulizer. So on those situations, like I was in a job where I pass a coworker and could smell it on her clothes, and I worked in a daycare, and she worked with the infants, and I said, that cannot be okay. And the director says, I can't stop her. I mean, she goes outside to smoke, but I can't tell her not to. I said, but then doesn't that affect the health of the babies and other people who have? He says, I can't do it unless they put something into law. Is that something that with people who are getting cancer or getting affected by secondhand smoke, has something of that been presented, or an idea to be presented?
And let me just say, Angelina, that's actually called third-hand smoke.
Third-hand
and
smoking?
I
Oh, okay.
just learned that a few years ago.
Oh.
So as first-hand smoke is you are smoking.
Mhm.
Second-hand smoke is you're in the room when somebody else is smoking and you're actually inhaling the smoke.
Mhm.
And third-hand smoke is when the residue of smoke is either on the couch, in the carpet, or on someone's clothing.
Oh.
But you make a very good point, especially, a daycare taking care of infants, and the smoker is not smoking in the daycare, but had just gone out to smokes in the clothes. So is there a role for public policy to somehow address third-hand smoking in certain situations like a daycare?
Great question, Angelina. I think that theoretically there is certainly a role for public policy to regulate that. I think realistically, at least in the state of Iowa, I think it's unlikely to get done when right now the mood is more in deregulation rather than more regulation. I'm curious, and I haven't done the research, but you brought up this, great question, especially in industries, and especially in healthcare type industries or direct care industries where we're dealing with folks who are sensitive or vulnerable. Are there states or countries that have some rules around that? And I'm not really aware, but what's really important for lawmakers is, I think most of us aren't that creative. We don't reinvent the wheel. We see who has already invented that wheel, and then we adapt it to our own state. And then we see what the outcomes have been in that state for various policies. So oftentimes when people have an idea, the first question is it being done already somewhere else? And especially if it's been done in a state that has a similar maybe political makeup of this state. For example, it turns out it's a Republican idea, it has a better chance of getting at least getting consideration. So those would be things that I think about is, are there policies like that work elsewhere in a different type of government, different location that we could adapt?
So let me give you a bit of analogy, see if you could adapt this. So and I'm pretty sure what I'm going to say is true, that it has been determined that companies can require employees not to smoke and can test them for smoking, and it can be a term of employment. And I think my hospital actually did that, and that you have to be a non-smoker and you can test to see whether you smoke. So could you say that preschool employment is limited to non-smokers?
I my asterisk, my disclaimer is I'm not a lawyer, so I don't know for sure if that's constitutional or not. But presumably, you look at some cases in, for example, Colorado, where state law of Colorado regarding marijuana is that you can use marijuana recreationally. But then there were employers who said, we're not going to hire somebody who's using marijuana. And it went up to the Supreme Court, who in the end said that these employers have that right to do that. That was in part because it adhered to federal law. So I don't know in a particular case where it's always legal to smoke if you can or not. But if you have had that,
Yeah, I'm pretty sure
experience,
that is
then-
true.
then I can see it.
The other aspect of smoking may be that, and I know there have been bills that have not been successful. So you can't smoke in public places, except there's one exception, and I'm sure you know the exception.
Casinos.
In casinos.
Mhm.
Casinos. And so casino workers have attempted to get that loophole closed. So it was intentionally, when the smoke-free bill passed Iowa, and that was maybe 15 years ago.
Yeah, I think
It
it's
was
2006 or
huge.
so,
It was
yeah.
huge.
Yep.
Nobody thought it was going to happen.
Yep.
And they put in that loophole to appease the casinos, and it's never been closed.
Yes. It's a shame. And this is an equity issue. You know, these are folks who have that job. Maybe they don't necessarily want that job, but that was a job they can get. And they, because they got that job, now are at higher risk of developing cancer. And where if they had any other industry or employer, wouldn't be the case. And when you're dealing with politics, you're dealing with lobbying. You're dealing with folks who can put a lot of campaign contributions behind their requests. And what I've found is the average person typically doesn't hire lobbyists and doesn't give the campaign contributions that match up with the special interests. And that's what we're going against.
Other questions? Yes.
Hi, thank you. I'm Bridget Greening. First of all, obviously, it's most important to be able to prevent cancer, but it's also then secondarily important to find it early if it is there. And so I want to thank you for your support of House File 2489, the insurance coverage insurance mandate for supplemental and diagnostic breast imaging. We do know, we knew going into it that it would only cover a portion of women who have insurance and that, but we felt that it was important to reach at least for some portion of the pie, and then we'll go at it from a federal standpoint.
Right.
But do you see more and more working towards individual coverage directives, such as, and I guess I'm thinking of where medically we're looking at patients more individually, and do you see that then maybe in the future working towards, like saying insurance coverage for higher risk patients need to be this? Doesn't mean blanket case that everybody needs this, but if a doctor says that this patient is higher risk, the insurance needs to be covered, needs to step up to it. Do you see that kind of going hand in hand with the more individual medical basis that we're going to?
Right. Kind of more tailored medicine and being able to have insurance coverage.
Insurance.
Right. I sure hope so. I think an example of that is we now do lung cancer screening with low dose chest CTs, chest CAT scans. And that's and a patient has to meet various risk criteria in order for insurance to pay for that. So they have to be between the ages of 50 and 80, and they have to have a 20 pack year smoking history. You take the number of years you've smoked and the average number of packs during those years. And so that is a way where it's kind of pre-established criteria of who is considered to be at higher risk for that cancer, that they would now qualify for that cancer screening coverage. Now, when we get into kind of, I think maybe more unique types of cancers or more unique situations, that's going to be harder. And for as long as we have this type of healthcare system we have, it's going to rely on the prior authorization process, and which can be long and onerous and oftentimes end at a dead end. There are some states, including Texas, who's working on rewarding health systems and doctors' offices who do prior authorizations successfully, meaning they order tests and treatments more appropriately than the average. And they're getting, I think they call it like a gold card, where they get fast-tracked for prior authorization because they're trusted as having ordered this appropriately. So I think there's ways that we can look at reforming the system for prior authorizations to help out patients who are in unique situations for whom there aren't guidelines risk stratifying them. But we're working with a piecemeal healthcare system, and it's going to take that sort of creativity to try to smooth out those processes.
Yeah. And Bridget, I would say that another example of where we are using the risk for developing cancer to determine whether a study can be done or not would be genetic testing. So we don't say every woman gets genetic testing to see if they have a mutation that might influence their chance of getting cancer. But if you've got a first degree relative who's had breast cancer, for example, well, that puts you in a higher risk, and then insurance companies will cover the cost. So it's part of it is to what extent do we go to the legislature to mandate insurance to do certain things, and then how many of those bills do we have to have for every single type of cancer and every single type of test? And so the legislature is one way of doing it. Other ways of doing it is through the health insurance process. Now, both can be difficult, but both can be successful in determining a woman with very dense breasts who has a history of cancer is eligible to have MRIs paid for. Whereas, the idea that every woman gets MRIs instead of mammograms is not going to fly with either the insurance system or likely with legislatures. But you bring up a great point. And by the way, we have at least 3 members of the Army of Pink in here. So you better, mind your P's and Q's, because they are very influential and successful. Yep. I would dare say they had a higher success rate than you had this year.
I would not doubt it.
But thank you for being such vocal. Yeah. Yes, George.
Yeah, and doctors, we've got a question from a viewer on YouTube. Mary wants to know, either one or both of you, do you know what the most accurate radon test is for a homeowner, an existing homeowner, either a brand name or a type of a radon test?
Yeah. So there are 2 main types of radon tests. One is a continuous radon test that tests radon live throughout the day and in days and seasons. Radon can be seasonal. It can change with atmospheric pressure, with wind conditions, heat. Those are expensive, and you need a professional radon mitigator to come in and set that up. But right now, guidelines are just a one-time screening. And I've looked at a few various commercial products out there, and one that actually a lot of states even contract with. It's called Alpha Energy Laboratories, I believe is what it's called. And it's about $16, and it comes in the mail. You put it in your lowest part of your home, And you'll have to follow directions. I think it's keep it open there, exposed to the air for I think between 2 and 5 days or 2 and 3 days, and you send it back in the mail, and they give you your readout. And it's considered to be accurate for that period of time for which it tested, but it's a really good start because if it's borderline, the borderline level is 4 is kind of the limit by the EPA standards. If you come out at 1, you're probably good. If you come out 3-ish or 4-ish, that's when I would probably call a radon mitigation professional to get a more professional test to find out what the true average is.
Okay, I've got a quick question that maybe you can't even answer quickly, but used to be we were told that a lot of these initiatives couldn't be met because there's just so much money to go around. We just don't have the money for it. Aren't we sitting on a budget surplus in the state of Iowa? And what's that money going to be spent on, and what's being done with it instead of meeting these goals and initiatives that we've talked about tonight?
Was that a planted question? I'm going to try to be very diplomatic here. Yes, we have a budget surplus. We have a budget surplus of, depending on what you consider to be part of the surplus, because there's some rainy day funds, but somewhere between $2 and $4 billion.
Whoa.
And some of that has been earmarked to tax relief, meaning we're going to turn that into the form of tax cuts and kind of money back for people, and then we'll use that to backfill our expenses. This all comes down to priorities. We have, I wanted $2 million to study why we have a cancer crisis in Iowa. $10 million were allocated to upgrade the elevators in the state capitol and the governor's mansion. Just as $500,000 were allocated for free bacon slicers to help boost our butchery industry. I could cherry pick here and there, but that just gives you a sense that you got to find out what your priorities are. And I'll tell you, we got money for it because there's probably lower priorities. We can take a little bit of money away here and there to fund it. And maybe I'm biased because I work in medicine, or maybe because I'm a human and have a body that, a 50% chance of getting cancer. I think fighting our cancer crisis is top priority for me of where we need to invest state resources.
All right. I think that's a good ending point. So, Dr. Austin Baeth, Representative Austin Baeth, thank you for being our guest, and thank you for supporting so many good, important public policies. We'll be up to see you at the Capitol again next year with the Army of Pink and also the American Cancer Society Cancer Action Network. If you have been watching this program and you know someone that might benefit from watching it, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer